today I'm going to talk about the Belatacept, which is the new hope for kidney transplant after kidney transplant after the solid organ transplant. So I have no, let's see, it started. I have no disclosures. So this is so funny. I put that actually everywhere, like in the middle of the slide, the end of the presentation, so everywhere. I don't have to do it this time because I'm doing the presentation.
You're marked present by default.
All right. So I like this quote by Winston Churchill saying, "Success is stumbling from failure to failure with low loss of enthusiasm." So, in the science world, it's like we have to keep trying and trying and trying. And even like people who are doing the basic science research would know that the experiment is not going to happen from the first time. So they have to keep trying until they succeed. Kind of like similar way with the babies walking, they have to fall down in order for them to be able to learn how to walk. And the same thing happens in life too. So this is a picture of plan. This is the first attempt of like doing the plan. For those of you who don't know what the flan is, this is like the perfect failure of a flan. But it's like it is a South American dessert that ideally should have like a caramelized top there, which I'm clearly missing here. So this is like the first attempt. It failed miserably. Second attempt, I overdid it. So it's like burnt. You can see over here. It's not working. Third attempt, maybe a little bit better, but it's still like overcooked. And fourth time is like the charm, which is like the perfect time.
So did you bring us in?
No.
It's hard to resist.
That's just a teaser. That's just a teaser.
What is the added sugar content? For SPK patient?
No, this is actually the only sugar when it's there, it's just on top. That's the only sugar. Inside it doesn't have any sugar in it. So I would say it's healthy. It's not healthy for any diabetic or SPK or any even borderline diabetes. They should not have this dessert.
They can look at it.
Yes, exactly. So the objective of this talk is not to talk how to make flan, but to talk about Belatacept. So to understand the mechanism of action for Belatacept, identifying the key studies leading to its approval and implication in organ transplant, learning about the benefit of Belatacept in kidney and the graft survival outcomes, and then review the safety profile for Belatacept and assess for the risk of opportunistic infections and malignancies, and finally recognize its role in preserving renal function in other solid organ transplants. So we'll start with a case. This is a 43-year-old African-American male in our clinic who had an end-stage kidney disease secondary to dysplastic kidney. He had a prior kidney which has failed, and then he was on dialysis for 10 years, after which he received his second transplant. Now, his post-transplant course was complicated by delayed graft function, and for the fellows, this is when we use dialysis within the first week after transplant. Because of that, we have to do a kidney biopsy to rule out the possibility of having an underlying rejection. So he had a kidney biopsy which showed acute tubular necrosis, and then 2 months later, he was off dialysis. However, his creatinine remained in the 4 range, and we don't like that. So we ended up doing a second kidney biopsy 2 months later, which showed no rejection stuff. But there's nothing in the kidney biopsy like any sign of chronicity or any sign of rejection in that kidney. So a little bit of like history background. So you have like all these pioneers in kidney transplant and in the organ transplant field. Some of them may have won the Nobel Prize. So for example, just to give you an idea, Alexis Carrel over here, he was behind the vascular sutures in organ transplant. Joseph Murray, he was kind of like the father of transplant. He was a plastic surgeon who did the first successful human kidney transplant. Gertrude Ilian, she was behind the discovery of 6-mercaptopurine, which is a derivative of the immuran that we're using. And then Rolf Zingernagel was behind the discovery of the MHC molecule and its implication in activation of the immune system. So looking at the timeline of where the immunosuppression, kind of like how long it usually takes for these immunosuppressions to be approved. So in the 1960s, we had only steroids and azathioprine along with total body irradiation available as a method of protecting the kidneys from rejection. In the 1970s, we had the anti-thymocyte globulin, followed by cyclosporin in the 1980s. And then it took a while until we had tacrolimus, mycophenolate, and basiliximab. And then sirolimus, it took about 27 years for that one to be approved. Finally, the Belatacept in 2011. So this is looking at the collaborative transplant study outcomes, looking at the graft survival over 10 years at different organs, and these were done between 1990 and 2013. So as you can see here, the kidney transplant had the best graft survival over 10 years. It's about 60 to 70. Now, of course, now we probably have better survival of the grafts with improvement in immunosuppression, followed by the heart, liver, pancreas, and then finally the combined heart, lung, and lung, they had the worst graft survival outcomes. Now, in kidney transplant, we kind of like have cardiovascular disease is the leading cause of mortality after transplant. And this is just to kind of show you, this is from the SRTR database in 2022, where they looked at the survival of the living donor kidney transplant. Now, they had it by different parameters, but I think it's true to look at the survival. So you can see the living donor at 5-year graft survival was about 80% in the older age group, more than 65, compared to like 90% in the younger age group. For the deceased donor kidney transplant, the 5-year outcome was 67.8 among the older population, and then 81% among the younger population. Also, as kidney transplant, we use calcium-urine inhibitors as the main anti-rejection medication in our regimen, and that by itself has the effect of worsening the blood pressure, worsening diabetes, or even creating new onset diabetes after transplant, in addition to the chronic changes that happens on the histology level, including anywhere between interstitial fibrosis, tubular atrophy, arteriosclerosis, and glomerulosclerosis. So in a way, we kind of like put all that into perspective. They wanted to come up with a medication that on one end spare the kidney from all the CNI toxicity that can happen, plus reducing all the risk factor that can happen because of the CNI nephrotoxicity, and improving like the high blood pressure, diabetes, and dyslipidemia, which ultimately reduce the risk factor for cardiovascular disease. So, Belatacept came to or the first time they started mentioning in Belatacept was in 1992. That was in the Science Journal. And then between that time and until 2004 is when they start talking about maybe let's develop that medication. And finally, you can see it was approved in 2011. So about 19 years, that's like a lot of trials to get that medication approved. So to understand, what or where Belatacept works, we have to understand the 3 signal model that is used to activate the immune system. So signal 1 over here is where the antigen presenting cell is presented by the MHC molecule to the T cell receptor, and that creates signal 1. The co-stimulation blockade happens when the CD28 on the T cell receptor binds to CD80 or CD86 on the APC, creating that co-stimulation block and co-stimulation signal. All of these will lead to activation, either the complex or a kinase of some sort that will be translocated into the nucleus, creating transcription factors that will ultimately lead to the production of the interleukins, which, again, will affect the immune system. So Belatacept works here at the co-stimulation blockade. This is a closer look. So Belatacept is basically a fusion protein consistent of the cytotoxic T lymphocyte associated antigen number 4, and it's fused with the FC portion of the IgG1. And that has a high affinity to bind to CD80 and 86, creating that co-stimulation blockade. So let's talk about the studies that led to Belatacept approval. So the first study was the benefit trial. This study, just to give you an idea, it was a prospective randomized double-blinded multi-center study that included 738 patients. These patients were 18 years or older. They received previously what we call the standard criteria kidney deceased donors or a living donor transplant. So the standard criteria now we replaced it with the KDPI system. The standard criteria will be reflected as the KDPI less than 85. And in a way, layman terms, this is like the best quality kidney. And their anticipated cold ischemia time was less than 24 hours. So you can think about like these patients are like the best donors or the best kidney that we can get. So they have lower risk of rejection and they have the better outcomes compared to the extended criteria donors. Now, all of these patients, they've received Belatacept as their induction treatment, and all of them were put on anti-metabolite medication. In this study, it was mycophenolate. And then everyone was on prednisone as part of the regimen, and the prednisone was tapered all the way, not less than 2.5. So they randomized these patients into 3 groups, 1 to 1 to 1. And the first group was the Belatacept more intense group. The second one is the less intense group, and the control group was the cyclosporine group. So the CNI that they used at that time, it was cyclosporine.
What was the dose of mycophenolate?
So it was, I believe it was like 1 gram. 1 gram.
In both
In
arms.
both arms, yeah. Total dose of 2 grams, like 1 gram BID. Yeah. Wait. So now, if you look at, again, they picked their patients carefully. So if you look at this study, you can see for the characteristics of the subjects, their age, they were like younger donors or younger recipients. I'm sorry. They were mainly Caucasian, and their end-stage renal disease cause was secondary to glomerulonephritis. So this is like does not really apply to our patient population. And also, if you look closely, their PRA was less than 20. So again, they picked the patients where the risk of rejection is lowest. Now, looking at the primary outcome of this study, it was the composite patient engraft survival, and then the composite renal impairment endpoint, then the incidence of acute rejection. So, just looking at the patient engraft survival, so when they compared the Belatacept groups to cyclosporine group, both the composite patient engraft survival, they actually were non-inferior to the cyclosporine group. The renal function, they did measure actually the renal function for the first year. And they did, after that, they calculated, or they did MDRD, used MDRD equation for the renal function. But for the first year, they did measure it with the iothalamate. And you can see here that both Belatacept arms, they did have a superior renal function compared to Belatacept group. And there was about 13 to 15 ml per minute increase in the GFR. And the calculated one was 15 ml per minute. Also, the degree of chronic allograft nephropathy, this is kind of like an older term. Now we use, it's just a discarded terms, basically. It describes all the chronic changes that happens on the level of the kidney graft. And they noticed that in the Belatacept arms, they had less chronic allograph nephropathy compared to the cyclosporin. And finally, the acute rejection was higher in the Belatacept. However, when they dissected these data and they looked at the acute rejection between the Belatacept less intense and cyclosporin, they found that it's actually non-inferior between just this group, the low intensity Belatacept and the cyclosporin. Now, looking at the kidney function, you can see that the GFR was better in the Belatacept group, and it was statistically significant. That's the calculated GFR. And in the bottom graph over here, they're saying that despite having higher risk of rejection in the Belatacept groups, they still have better GFR compared to the cyclosporin group. So they compared with rejection and without rejection, and in all the groups, they had a higher measured GFR in the Belatacept arms. Now, looking at the secondary outcomes, when they look at the new onset diabetes after the transplant, it was actually not statistically significant between the groups. And serum lipids and hypertension were actually better in the Belatacept group. So for the new onset diabetes after the transplant, they defined it as the use of medication for diabetes after 30 days from transplant. That's the definition that they use. And it was not statistically significant in this patient population. Now, looking at the opportunistic infection, I know this is a busy slide, and that's why I'm highlighting everything. There was two patients in each, one patient in each group of the Belatacept developing PTLD in that arm. And then the risk of infectious causes like CMV, BK, and urinary tract infections were not different among the groups. Now, they took the same study and they followed the same patients for 3 years. And in the 3-year outcome, I know I did not put all the data there, but the GFR persisted to be better at 3 months and in both Belatacept arms compared to the cyclosporin groups. Now, most of the patients with the Belatacept group, they belong to the CKD stage 2, and the cyclosporin were mainly in the CKD stage 3. Now, in the lower graph over there, they're saying that patients in the Belatacept arm had a survival advantage if their GFR was more than 30 microminutes compared to the cyclosporin arm. Finally, the 7-year outcome of the same study came at the New England Journal of Medicine, and they followed the same patients for 7 years. Now, when they looked at the probability of either the graft survival or the patient survival by themselves, in those two graphs over here, those both were not statistically significant between the groups. However, when they did the composite probability of patient and graft survival, they both actually had a maybe advantage in the Belatacept group compared to the cyclosporin group. Now, the GFR, again, it continues to get better.
Effect size, I'm so sorry.
What was it?
Effect size on that last one.
So it's like both the graft and patient survival together, they actually were significantly better, statistically significant, and they were better compared to the cyclosporin group. It's just like each one individually is not statistically significant, but if they can find them, they have to come up with good outcomes for the New England Journal of Medicine. All right, so yeah, that's how they, kind of like, if you look at like the outline, it's actually kind of like misleading. So you have to like dissect each results separately. So yeah, the glomerular filtration rate, again, this is the calculated one at 7 years after the transplant. It was about 70 ml per minute in the more intense Belatacept. Less intense, it was 72. Cyclosporin was 45. So you can see like it diverged kind of like significantly among the two groups compared to the cyclosporin group. Now, interestingly, they found out that in the study, the number of or the development of de novo donor DSA was less in the belatacept arms compared to the cyclosporine group. Actually, if anything, this is like probably the selling point of the belatacept. And it was both in both classes of the PSA classes compared in belatacept compared to the cyclosporine group. So just kind of like summarize that benefit trial. The composite patient and graft survival was non-inferior in the belatacept arms. And at 7 years, it showed more benefit compared to the cyclosporine group. The GFR at 1 year was significantly higher in both Bela groups, and that effect persisted at 3 and 7 years compared to the cyclosporine group.
So just
Yeah.
a quick question. So was everyone in the Belatacept group, they continued on Belatacept for 7 years?
Yes,
And cyclosporine continued on and no one switched?
No. there was no like crossover.
Do you know whether, I don't know whether, but the NEJM paper, did they say what was the power for that particular analysis?
You mean like the p-value?
Not the, by the time the sample must have gone down substantially, so I don't know whether there was enough power to say, I mean, it is statistically significant, but like, do you know what's the?
That happened actually in the next trial,
Okay,
where the, like
sure.
most of the patients died and they had. I'll talk about it, but it happened with the other trial, the benefit EXC trial. Yeah, so the incidence of rejection was at 12 months was higher in the belatacept groups, but again, despite that risk of rejection, the composite patient and graft survival was not any different. And then the new onset diabetes after transplant was not significantly different between the groups. And then there was less development of DSA in the belatacept arms. And finally, there was the high risk of rejection in the PTLD group. I know I did not mention it there, but there was about 10 patients who actually developed PTLD in the whole study for like all the groups. And they found out that the highest risk was in EBV seronegative patients. And that's why now, for belatacept, we only use it in seropositive patients.
Also, in the original study, that was not an exclusion criteria. Right?
No, it was not. They
And
included
when
that.
they found the incidence was higher, they looked back and they saw that
It was higher, yes, but there was also, so two things actually. They saw that seronegative had a higher risk of PTLD. And then the seropositive patients, some of them developed PTLD, but those patients did have an underlying CMV. So that may be attributed, having an underlying CMV can, cause PTLD in the seropositive
that
patients.
first study caused the labeling for the EBV.
Yes, to be not used in the seronegative patients and only in the seropositive patients. Now, so movies give me a break.
Is there any mechanism for like why those patients had less DSA? When they're on belatacept?
So if I'm writing, and anybody from the transplant people can, correct me if I'm wrong. It was probably related to the T regulatory cells. That's what I'm thinking. That happens because of the Treg cells, compared to like the other.
I think when you have this co-stimulatory blockade at signal 2, it prevents the differentiation and maturation of those T cells. It has more immune modulatory properties, which obviously the activated T cells would stimulate your B cells to differentiate into plasma cells, and those plasma cells which are HLA antigen specifics are known as DSA. So that's where the immunosuppressive mechanism of belatacept lies essentially. It prevents B cell activation and B cell forming plasma cells. That's why it can cause more PTLD, because PTLD is EBV related. So I think that's a possible explanation. But when belatacept acts at signal 2, T cells have already been activated at signal 1. So you could argue that T cells have already been activated, so the T cell would differentiate. So why there is less DSA with CNIs?
No, the principle is for signal 1. That's why signal 1 and 2 come together is with activation without cross-stimulation, they will have apoptosis, nothing will happen down the line. They have to both happen. So it's either you did calcineurin inhibitor, then you do the signal one, or you do the alternative, the blockage, you block either, nothing will happen. I mean, it will not. That's why it's one or the other. That's why it's a substitute.
Now, this is the other study. It was like a parallel study that was happening at the same time, but this one did have a different patient population, or different patient subjects that were included in the study. They call it the benefit EXT, just because this one had, like, if you look at the inclusion criteria, they looked at 18 years and older patients, and then patients who received the extended criteria donor, or what we call the KDPI more than 85. Now, back then, that extended criteria donor, they included donors who are 60 years old and above, or donors who are 50, but they had an underlying hypertension. So their serum creatinine was 1.5, and they had a history of CVA or TIA. And then they also included cold ischemia time of more than 24 hours, and then donation after cardiac death. So, compared to the other patient population, this is a more or a lower quality
Margin of
kidneys. Yes, they're not good quality kidney. And again, they wanted to see because the outcome, they randomized patients in a similar manner to what they did for the benefit trial with the more intense, less intense, and then the cyclosporine group. Now, looking at the same thing with survival, it was not inferior in the Belatacept arms compared to the cyclosporine group. The renal function, so you can see over here, it was actually numerically higher in the Belatacept arms, but it did not achieve statistical significance. There was only the statistical significance was achieved between the more intense Belatacept group and cyclosporine group, but not both groups against cyclosporine. And there was about 6 to 8 ml increase in that calculated GFR in the Belatacept, but again, it was not statistically significant. Now, the risk of chronic allograft nephropathy also was lower in the Belatacept group. Now, interestingly, the risk of rejection was actually non-inferior between the Belatacept arm compared to the cyclosporine arm. Yeah, so that's like the difference between the two patient populations. Now, this is for the calculated GFR. You can see like they're numerically better, but again, they did not achieve statistical significance in those extended criteria kidneys. Looking at the metabolic outcomes, same thing. Diabetes, new onset diabetes after transplant was not statistically significant, but the lipid profile and the blood pressure was better in the Belatacept arms.
Biopsy, what was the time frame before the biopsy? Because I'm surprised there's no difference in chronic allograft nephropathy. This is marginal kidney, you're giving CNI, and still, is it a year after?
This is a year. This study is for a year. Yeah, those outcomes only for the first year.
Supposedly, it's already so disadvantaged to be marginal and still getting calcineurin and still, okay.
Yeah.
Thank you.
Now they, again, they followed the same pattern with this study. They looked at it, I'm sorry. Now, looking at the adverse events in this benefit EXT trial, I know it's not shown here actually, but the cancer risk was not different among the three groups. And the PTLD was noted in over that 1 year. There's one in the more intense and 2 in the less intense group, and then 2 additional ones in the second year developed in the more intense group. Now, like I said, 3 out of 5 patients were in the EBV seronegative, and 2 of them were in the EBV positive, but they did have a CMV infection. And 4 out of 5 patients, they did have a PTLD in the central nervous system.
No. So is this a separate study from that previous one?
So this is the benefit EXT.
Right.
Excellent.
Yeah, but they still gave it to seronegatives anyway in this iteration.
Yeah, because they were like at the same time,
Right, okay, so they did not know. Okay.
Yeah. Yeah, so it was like the same thing. I think after the first year, they decided to do it only in seropositive patients. Yeah, but it was like a parallel study, so it's like, they didn't know then. And the same thing with the BK, CMV, the infection risk was the same in those two groups. Now, the 3-year outcome of this study, the same thing, you can look at the GFR, it's definitely better in the Belatacept group, but it's still not statistically significant. And now, looking at the 7-year outcome of the same study. Now this is also gonna be interesting because they looked at the survival probability to either one. Now, the graft loss or death, it was not statistically significant. When they looked separately at each one, also it was not either the time of death or the time to death sense of graft loss, it was not statistically significant. Now, they tried to do it better, so they added the GFR less than 20%, and they found out that it was only significantly better in the less intense group compared to the cyclosporine group. So again, you can argue, but it's still not, at least it's not inferior. Now, again, the GFR, this is where I know it looks good, but they said they could not achieve the statistical significance due to, there were like a lot of patients, either they died or they, lost to follow-up, so they could not achieve the statistical significance. But again, numerically, it was higher. Now, to summarize this benefit EXT trial, the same thing, it was at least non-inferior. I could not say that they added a benefit to the composite. Sorry.
Could you go back? So this is a 3-year follow-up or
This is a 7-year follow-up.
7 years?
Yeah.
Okay, and 6 years.
Makes a lot of patients lost. Follow.
Is that all to death? 167 to 69?
Either like
Or some of these didn't, it
either
was a rolling enrollment and.
it's like they either like lost to follow-up or they died or they like lost their graft. So all of that, they put it at 0. So like it kind of like made the statistics a little bit deviated, yes.
But they didn't make it 0, right? That's just the data that's gone.
Yeah.
Okay. Because 0 is different, right? So,
So again, it was not inferior in the Belatacept groups. Now, the GFR, like I said, it was numerically higher, but it was not, the effect of it persisted, but it was not statistically significant in regards to the renal function. There was no difference in the incidence of acute rejection as opposed to the benefit trial. And there was no significant difference in the new onset of diabetes after the transplant, but the lipids and blood pressure tend to be better in the Belatacept groups. The same thing, they noticed that the donor-specific antibody also was lower in the Belatacept groups. And finally, they put in with this paper that the high risk of PTLD persists in the EBV negative, seronegative patients and patients who were seropositive but with underlying CMV. Now, this is just kind of like a quick systematic review that was done in 2014, looking at 4 studies. And they concluded from that systematic review that there was no difference in patient or graft survival. There was no difference in acute rejection, no difference in malignancies, and no difference in PTLD. They did have better GFR, lower blood pressure, lower non-HDL, and lower triglycerides. But again, the diabetes did not have any difference in the systematic review. Now, since we've been talking about cyclosporine, this is actually not the medication that we use for most of our patients, and we use tacrolimus as the main calcineurin inhibitor. So we have to look at the outcomes using tacrolimus as opposed to cyclosporine and compare it with Belatacept. So this study was done by our group, where they included patients from 2011 to 2014. And they looked at the outcomes. So the data were from the SRTR data. So it was like a retrospective study looking at it was only done over 1 year. So it did not have a longer follow-up. Now, the results they looked at, they separated patients into 3 groups. The first one, the group that received Belatacept alone, And then we have Belatacept as well as low-dose tacrolimus, and then patients who received tacrolimus alone. So these are the groups. So they look at all recipients and they found out that the renal function was better in either regimen that contained Belatacept group, and it was statistically significant. It was actually, when they applied, those to the benefit eligible patient, they actually showed no difference in their GFR at 1 year. And there was a benefit for the benefit EXT eligible recipients only. So those are the ones that had maybe superior renal function in the Belatacept arms compared to the tacrolimus arm. Now, looking at the results for the acute rejection, you can see in all groups, whether it's all recipients, benefit eligible recipients, or the benefit EXT eligible recipients, all of them in the Belatacept arms, they did have statistically significant higher risk of rejection. Now, I think the numbers were comparable to the one that were reported in the benefit and the benefit EXT trial.
This must be low intensity or?
No, this is just retrospectively looking at patients who either received, we use the low intensity, Belatacept group, and Bela plus TAC or tacrolimus alone. So they didn't have a low intensity, high intensity. Yeah. Now,
It's T cell mediated, though, right?
yeah,
Cellular.
it's
Yeah.
T cell mediated. Yeah.
The population size is 50,000 versus 500. I'm just wondering, these are crude rates? Like, what about, are these adjusted rate for patient
They're
characteristic or
unadjusted.
are they
They're
just crude?
unadjusted.
So what would you adjust for normally? Like,
They adjusted for, I don't know if it was like either, we had an issue with this paper where not all centers were using Belatacept similarly. And then they adjusted for, I don't know if, Dr. Santos, do you remember? Was it-
So long ago.
No, but one of the argues was that the Belatacept use was not uniform
This is the APC.
transplant, across transplant centers.
10 years ago.
right, no,
But it was
the
an
question always being when you're 1 to 100 distribution into arms, the 1% arm has some unique characteristics that it's very difficult to adjust in 100. Like we do this for USRDS also.
Yeah, I
So.
believe it's adjusted, but okay. Now, looking at the 1 year biopsy, now just to like kind of look at whether the lymphocyte depleting induction would have an effect on the risk of rejection or not. So when they looked at patients, of course, the Belatacept arms did have higher risk of rejection compared to the tacrolimus arms, but you can see that when lymphocyte depleting induction was added or was used between the Belatacept alone groups, you can see that it added benefit and it reduced the risk of rejection, only in the Belatacept arm, not in the Belatacept plus tacrolimus. Now, in the non-lymphocyte depleting induction, they're suggesting that adding that low-dose tacrolimus to the Belatacept also will reduce the risk of rejection between these two. Like when Bela is used alone compared to tacrolimus and Bela, it would also reduce the risk of rejection. Now, for the outcomes, metabolic outcomes, the new onset diabetes after the transplant was statistically better in the Belatacept arms compared to tacrolimus. There was no statistical significant difference in the de novo PTLD development or any new onset malignancies.
And I think this is indirectly showing that, what we do in clinic is somebody is uncontrolled diabetes in tacrolimus receives the cyclosporine, because remember the original comparison was cyclosporine and there was no difference. Now that you compare to tacrolimus, then it shows you indirectly that benefit.
So just to conclude, I know I did show that the patient outcomes, but they were actually not inferior. The composite patient death or graft loss. The superior renal function was only in the patient who had marginal donor kidneys. there was a higher risk of acute rejection. And yeah, all of the belatacept rejections are actually more like T cell rejections that improved either by adding a lymphocyte induction or by adding tacrolimus, especially if we use it in the non-lymphocyte depleting. And the risk of new onset diabetes after the transplant, it was significantly lower, but there was no difference in either the PTLD or new other malignancies.
The follow is 1 year.
It's only 1 year, so it's a short,
Malignancy, you
Yeah.
take it to the grade.
so it's a short
Yeah.
year because it's
It's a
like,
very short gestation for
yes, for like
malignancy to develop.
the cumulative.
Couple PTLD, they were seronegative ones or not? Was it no, sir, none of, no, but seronegative.
Yeah.
Alright,
Yeah,
I
no
don't,
risk, no difference in the risk of PPL.
I actually don't know, this, I don't know if they were, but I don't think that they were included.
No difference in the risk of PPL.
Yeah, no,
And-
no risk,
and-
but he's
I
asking if
think
it's seronegative or
in
positive.
any study which is seronegative, the incidence would be higher in Belatacept or all of the studies across, but if they are seropositive or they had immunity, there is no difference. It is random, even in close to, let's say, 200, close to 250 patients in each arm. There have been in recent studies, even like 2 or 3 cases, or maybe 1 case in seropositive. So there's no difference, yeah.
Okay. Now, this is just to assess the risk of opportunistic infection in belatacept in kidney transplant patients. This was done, it's actually a French study done in 14 centers, and they included patients between 2010 and 2017. Now, they argue in this paper that their patients are more sick and they're like, higher risk of rejection patients, they have a higher PRA, they have, it's kind of like the population that we see normally in our clinic as opposed to the one that was studied in the Benefit EXT and the Benefit trial. They divided these patients in that population into 2 groups, the one that had belatacept conversion in the first 6 months after transplant and people who had it late, which is after 6 months after the transplant. These are like all the patients who had opportunistic infections, and they were 34 patients. They had 42 opportunistic infection in those 34 patients. Most of these infections were either CMV infections or CMV disease and PCP pneumonia. You can see the numbers over there. Now, in this study, they had 2 patients who had PTLD in the central nervous system, and 2 patients who had PMF, progressive multileukoencephalopathy. They, concluded from that study that most of these opportunistic infections, they did occur in the patient population who had early conversion to belatacept within the first 6 months, and also in patients who had low graft function, and they defined that as a GFR less than 25. They suggested in the study it's probably a good idea to maybe extend the prophylaxis dose for both CMV and PCP in patients who are receiving belatacept. Now, I know there were actually a lot of studies that were done in kidney transplant using belatacept, and there were other studies using belatacept in more solid organ transplant, but I'm just going to point out a few studies, and then there's a lot of studies, so that needs another rundown to talk about this. But they did some studies where they used de novo belatacept, like right from the get-go, and they did some studies where they did use belatacept, convert the CNI to belatacept after 6 months. So this study, it's called the BEST trial, where they looked at kidney transplant recipients in the setting of different induction therapy, and I'm going to talk about it, but they looked at it in the setting of steroid withdrawal. So again, they divided these patients into 3 groups. 1 patient received belatacept with alemtuzumab induction, 1 received belatacept with thymoglobulin induction, and 1 did receive thymoglobulin induction with tacrolimus. Now, all of these groups, they did have steroid withdrawal after 5. They started on steroid, and by day 5, they were off steroids. Looking at this, they I know I did not put this, the death sense of graft loss was not significant. I know it's like, they're like over here. It was not statistically significant among the three groups. In the death sense of graft loss, it was also not significant among patient survival. The freedom from biopsy proven acute rejection, they were actually both Belatacept groups did have a higher risk of rejection compared to the tacrolimus group. So they're saying like regardless, both of them are lymphocyte depleting treatments. So it doesn't matter whether they receive alemtuzumab or ATG, they still have a higher risk of rejection. And those rejections were T-cell rejection. They did not report any antibody-mediated rejection in this study. Now, there was a 2-year follow-up study, and it continues to show no significant difference in either the death or the death sense of graft loss. Now, just to kind of like outline some of the studies that were done in kidney transplant, and these studies are the study that they converted the CNI into Belatacept. So the first study up there, it was a prospective randomized study. Now this one looked specifically at patients who had stable kidney function. So they didn't have any, chronicity, they did not have any dysfunction of the renal graft. They just put them on Belatacept between 6 to 60 months post-transplant. And they noticed that the graft survival was almost similar in both groups. And they had a still higher risk of rejection in the Belatacept groups after 2 years. The second study, it was a retrospective study. Now this one looked at a different patient population where they have a graft dysfunction, and they defined that as they did a biopsy, and it showed some degree of chronicity, some degree of interstitial fibrosis and tubular atrophy, but there was no evidence of rejection in those kidneys. And the survival rate was 94, and the death sense of graft was 85. And again, the same thing, 7 out of these 53 patients had acute rejection after 6 months post-conversion, but we did see improvement in their GFR after 6 months. The last study was, now this one is a prospective study. It was interesting because these are patients who had chronic active antibody-mediated rejection. So they have chronic active antibody-mediated rejection. They looked at, their chronicity score and did a biopsy to look at the improvement in the microvascular inflammation or the degree of chronicity. And they found out that the biopsy before and after conversion to Belatacept didn't show at least any worsening of the microvascular inflammation or the chronicity. They said that maybe there was a trend toward improvement in antibody-mediated rejection. But again, the idea is maybe using this in patients with active chronic antibody-mediated rejection is to reduce the donor-specific antibody and maybe, in a way, trying to arrest that progression of the ongoing antibody rejection. And it's just maybe for the last few minutes, I would like to mention the studies that were done in other organ transplants. I didn't touch on the lungs. I don't know. I know it's like it's a whole other topic, but I picked these 2 studies. The first one was a case study. So before actually talking about this, they noticed when they did try to use Belatacept de novo after liver transplant. They noticed that patients had a higher risk of death and graft loss, liver graft loss, using Belatacept de novo. So there was a study, they stopped the study because of that higher risk of death and rejection. Now, in this case series, it was, I believe, 8 patients or maybe 12, but it was not that many patients. They looked specifically at patients who had a kidney transplant with a prior liver transplant. I think we had 1 patient we did this on. And they noticed in this case series that all these patients did not have any dysfunction of either the kidney or the liver. Risk of rejection was the same, risk of infection and malignancy was the same. So there may be, again, suggesting it might be safer to use Belatacept in patients with kidney transplant with a prior liver transplant. However, again, this is a case series where they need a larger studies to kind of like comment on this. And finally, in patients who received simultaneous kidney pancreas transplant. They did a prospective trial, and they tried to withdraw CNIs and just use Belatacept instead of CNI. And what they found out, actually, there is a higher risk of pancreas rejection after withdrawing CNI. So it's interesting because in this study, they started withdrawing the CNI, and then in the middle of the study, they noticed that so many patients are getting rejection, they stopped withdrawing the CNI and they kept them on a smaller dose of tacrolimus. So there was a higher incidence of pancreas rejection. There was no antibody-mediated rejection, and kidney survival was the same kidney graft, and there was no kidney rejection in this SPK patient population. Now back to our patient, just to give you an idea, this is where we started the Belatacept. Now, I know I did mention in the biopsy that he didn't have any chronicity, he didn't have kind of like indication to start Belatacept, but the idea was he was like a big muscular guy. So we're saying like, okay, maybe that creatinine is just related to the overproduction, muscular overproduction of creatinine. So we actually put him on Belatacept. The idea is to basically spare him from the CNI nephrotoxicity and decrease the risk of that impact on his GFR. So in conclusion, Belatacept works by blocking the co-stimulation signal, and it's contraindicated in EBV seronegative patients due to high risk of PTLD. It enhances the renal function with no significant impact on either the graft or the patient's survival. Like I said, it showed, at least in the benefit trial, there is a higher risk of rejection. However, that risk of rejection did not impact the long-term outcome of that graft or the patient's survival. And then finally, it's contraindicated. It's actually a black box warning on the package insert for Belatacept not to use it in liver transplant patients due to high risk of graft failure and death. Although, again, we may use it cautiously in patients with kidney after liver transplant. And speaking of, again, it showed more pancreas rejection, and there was no difference in the kidney rejection.